So welcome everyone to our webinar series for the Association for Fertility and Reproductive Health. Good evening, everyone. My name is Rose Ogbeche, the Secretary General for the Association for Fertility and Reproductive Health, and I will be moderating this session with Dr. Olugbenga Ogunkoya. Dr. Ogunkoya, can you say hi, please? So
hi to everyone. Hi to everyone.
Thank you. All right, so thank you very much, everyone, for joining. And we will be kicking off with our counseling series today. And it's really our pleasure from the training committee of AFRH to welcome you all to this series of meaningful discussions. Today, we are honored to have with us Mrs. Bamyil, who is a distinguished and licensed clinical psychologist and a certified IVF mental health professional. She has dedicated her career of over a decade to supporting individuals and couples navigating the complexities of fertility treatment. She focuses on anxiety, depression, trauma, and relationship issues. Her extensive expertise will help, a lot of our IVF couples, as we all know, and support through the journey of parenthood. Just a side note, she's a member and currently serves as the treasurer of the Association for Fertility and Reproductive Health, and she's also actively involved in other professional organizations in the United States and in the UK. So in this session, Mrs. Saleh will be shedding light on the vital role counseling plays in ART. Hopefully this will equip us both professionally as individuals also when we are seeking guidance in this field. So without further ado, please let's welcome Mrs. Bamyil Saleh. And just a little housekeeping rules. If we have questions and answers, please do not hesitate to drop it in the box down below so that we can take it immediately after the presentation. So Mrs. Bamyil, over to you, please. Go ahead and share your screen.
Unmute yourself, Mrs. Bamyil, please. She might be talking, but we are not hearing.
Afternoon, everyone.
Okay, we can hear you now.
Thank you. Can you see
go ahead and share your screen?
Okay. Can you see my screen now?
Not yet. Okay, it's loading now.
Okay.
Okay, fantastic. Good.
All right. Thank you. So I'll be discussing emotional support and counseling in ART. And this is who I am, already been said. Yes, I want us to know, I want to bring out some certain truths about the psychological and social stress of infertility and ART. It's no news that up to 50 to 70% of IVF treatments are unsuccessful. Now that's where the counseling is high. And then that the emotional burden of ART is especially, or failures lies on the women. That is another fact. It's also true that most women lost or lose up to 23 hours of work per cycle. This we know from the frequent visits to the hospitals. And then we also know that harmony between couples does not remain stable over fertility cycles. This is the outline I'll be discussing. I know I have 30 minutes, so I'm going to try to work in time. As a form of introduction, it's very heartbreaking to discover that the loss or the stress that patients undergo in IVF can be equated to, or even more than, the death of a family member. So if you have experienced that, then you understand what our patients go through when they have IVF failures or when they are going through treatment. And also it can be equated to separation or even a divorce. Now, in all of this, patients experience these differently based on their personality and life experiences. There are certain risk factors for emotional problems in ART cycles, and they are: one, gender. We know that women are emotional beings, and so the toll is harder on them. People with low occupational status, because they are thinking about the loss in money, how long it has taken them to generate or get money for another cycle or for a cycle, and some of them take loans, and there's so much stress and burden financially on them. Other risk factors are difficulty to understand the reality of infertility. Now, when patients come, all they want is a baby. They don't want to hear about success rates. They are not focused on it may or may not work. So that is an unrealistic thought or feeling. The unsuccessful treatment in childless couples is also a risk factor. Those that have had to do multiple cycles, when there's high stress levels during treatments, the high cost of IVF cycles, like we know, the cost does not come down, it keeps increasing. Then those are coming with unrealistic expectations, and then deficient support system, those who don't have a good system to fall back on when the cycle is over. So all of these are risk factors that predispose these patients to high emotional problems. Now, what are the stressors? These are natural or man-made, okay? Sometimes it's physical, the physical appearances at the hospitals. Our patients are not sick, but they have to come to the hospitals. Sometimes emotional, so if they are not emotionally balanced and they appear to your clinic for a cycle, then that can be another stressor to them. Marital, if there is discord between the couples. It could be social pressure from their family members. It could be religious. There are certain aspects of ART that some religions don't subscribe to. And then financial too, and then time. So if your biological clock is ticking as a woman, it feels like now, I want it now. So those are some of the stressors that are there. And once a couple is going through an IVF cycle, there are psychological responses that are evident or that show when they are doing cycles, and they are multiple. Some of them, like enumerated here, are frustrations, anger, fear, isolation. Forgive me, I'm a psychologist, so I'm doing a reverse order. I hope that's okay. Grief, jealousy, irritability, anxiety, depression, helplessness, name them. So all these are issues that psychologists or mental health specialists should deal with, and will be aware of them and also have the skills to be able to help our patients. Who is a fertility counselor? Counseling happens at every level of the fertility cycle. From the front desk, there's a little bit of counseling or information giving. The doctors do this, the nurses do this, embryologists do this. But the most critical part of the couple's emotional being must be handled by a specialist, a graduate with a degree in mental health profession, who is licensed to practice, who is trained in the medical or psychological aspect of infertility, with a minimum of 1 year clinical experience, and with regular attendance at certified continuing educational programs such as this. What is IVF counseling? Of course, it's a relationship between the counselor and the counselee or the couples. And what does this relationship do? It explores the difficulty, the distress, the uncertainty, or the dissatisfaction that clients may be experiencing. There are certain key principles in counseling. Number one is that it must be confidential. Second, it increases the client's ability to make choices. Choices for treatment, decisions whether to stop or continue, or to go with what is best as outlined by the professionals. It includes information giving, even though the patient has the autonomy to decide. It does not involve this decision. So you don't direct the patient, you don't advise, you only counsel and give information and guide for them to take their decision. It can be done for individuals as well as couples, and it can be done only by qualified counselors. So if you're not a psychologist, there are counselors who are trained to do fertility counseling. There are nurses and there are counselors that can do that. And why would you want to have counseling, for instance, for a couple? One, it helps to explain the implications of the course of treatments that they are doing, especially regarding their family and children, born or unborn, so they face reality at the counselor's desk. It provides an emotional support for them before the treatment, during the treatment, and also after the treatment. So it assists them to develop successful coping strategies for dealing with both short and long-term consequences of infertility and the treatment, and help them to adjust to accommodating the particular situation where IVF cannot solve their problem. You encourage them for other available choices like adoption. Pardon me. There are certain benefits for this psychological support in IVF. It will improve their emotional well-being. You know, having to try getting pregnant and not achieving success can break the couple down. So it improves their emotional well-being, whether they succeed or not. It enhances relationships. It's advisable that couples go through fertility treatments together, where they share information, where they share decisions, where they support one another. So it will help to enhance their relationships. It also will increase treatment success rates when they are in it together, and gives them some kind of control or empowerment over their lives and decisions. What are the types of psychological support that are existing? We have counseling and therapy. Counseling is what we do on a daily basis. We have presence of support groups. Now we have online support groups. Some are registered, some are not. We also have currently a support group for professionals of ART, where patients can get help, get information, and get resources to strengthen them. Then we have mind-body techniques that can help clients to relax and go through their IVF sessions. And then, of course, education and information can never be overemphasized. What are the key competencies for psychological care? It's communication is at the forefront of everything. And what do you do when you're communicating with them? Of course, you must relate with the patients and create a rapport. If they don't trust you, they will not be open. So you create a rapport with them, be you a physician or an embryologist or a nurse, so that they will be open and discuss their issues with you. You ensure, you show understanding and ensure that they also, you get feedback from them that they are getting the information that is key. You pay attention to the emotional impact of infertility. It's not news that when patients come to your desk as a counselor, that most times they break down when you have discussed with them and you've opened them up to reality. That breaking down in counseling is a sign of healing or acceptance of reality, and then accepting to build their coping strategies. So you involve patients in decision-making, very key. Most times is the women that come to the clinics, but you ensure that they discuss with their partners and decision is from both so that you don't get in trouble at the end of the day. You pay attention to their specific needs. Each patient is handled differently, individualized care, very essential. And then you have to be sensitive. Sensitive, not in just hearing, but you are monitoring their expressions, you are monitoring their gesticulations so that you are able to pick certain areas that you will refer to the mental health specialist and that there's trustworthiness. So communication skills, very essential, respect, competence, involvement, and information provisions are associated with better patient well-being, not just in ART. What do these patients expect from us? They expect that the clinic is specialized to care for their fertility needs. They expect the fertility staff to be competent to give personal care. So apart from the education and the certification, your approach, your attitude, very key. They expect minimal waiting times. They expect access to information, both verbal and written. They expect explanations about treatments, about results and costs. They expect to be involved in decision-making and that both partners should be involved in the treatment process. They expect staff to understand the emotional impacts of infertility because if you don't, you cannot address their needs. They expect to receive information about psychological care. If it is available, if it is not, you refer, even though it is optional. They expect to have access to that care before, during, and after their treatments. So what do you check during treatment? Of course, the well-being while on medication, so you keep a tab on them to be sure that they are not experiencing side effects or they have not stopped medication or that they are taking them right. You also ensure that you check spousal support, that when decision is taken, that both parties are carried and that they are coping with work especially, and that they are discussing with other partners. You can't stop this. It happens involuntarily. Patients create relationships while they are waiting and they discuss with other patients. But there must be clarity for them to know that each patient is here and is treated individually. So they can tell you, you did this for Mrs. A, why not for me? I saw her own is going well and why not me? So you ensure that that discussion is not to the detriment of the patient. So how then do we manage the expectations of these patients during the IVF cycles? You ensure there's understanding of success rates. That's what we do at every desk. The doctor says it, embryologists say it, nurses say it, and the counselor also say it. Because when they come with unrealistic expectations, all they are looking at is the goal, not the process and not the success rate or the percentage success that they may get. You discuss expectations with our patients so that you clarify unrealistic ones and you help them strengthen the ones that are real, okay? You'll be informative about alternative options if there are. So the mental health specialist or the counselor must be knowledgeable about all this. And then they help the patient focus on the present and take it one step at a time. That's during their treatment. You encourage spousal support and self-care, very critical. Again, their support systems is what you check during an IVF cycle. And some of those that support our spouses, very critical. Family and friends, for those who are open to share with their family and friends. Then there are formal, like I said, and informal support groups. Some of them are formed at the clinic. They must also get support from the healthcare providers. We show them a lot of support. And then the mental health professionals. Online resources, there's a question mark. Some Google doctors just take anything that they see online that is not verified, and so they work with it. So you must also help to clarify that. Following an IVF treatment, this is the critical aspect of it, how to help the patients to cope with failure. It starts from the way you break the bad news. And once you do that and you're successful, the next step is to follow up the patient immediately. You encourage them to grieve because Having a failed IVF cycle is similar to grief period for some of the patients. So you encourage them to let it out, take their time and grieve. You encourage them to seek support where it's necessary, to explore other IVF options. Of course, this will be after they would have healed from the failed cycle. And then you inform them to be able to wait 1 or 2 months before another cycle, and then help them to set new goals. How do patients normally cope at the end of treatment? It's the same thing as postpartum depression. So a lot of following up. If you don't monitor them or follow them up, some of them can fall into serious emotional issues and depression as well. So the counselor works collaboratively with them. I have put here a categorization of the types of patients that we see in the clinic. And funny enough, there are more than this, but I picked a few interesting ones. Now we have patients that come to the clinic that are hopeful and optimistic. These are patients that no matter what you say, they are on the positive side, they are resilient, they want to always do it and do it and do it again. Another cycle and another cycle. So what are the needs of these patients when you identify them? You must keep reassuring them, help them with positive reinforcement and encouragement. And this will give them hope while managing their expectations. Remember, they expect positive, so they don't see anything less than, so you keep reassuring them. Then we have the anxious and worriers. These are patients that are constantly worried about the outcome of treatment, so they are always anxious. You must follow them bumper to bumper and ensure that their anxiety level is within check. What are their needs? Emotional support, which can come from the clinic and come from their support system. You teach them relaxation techniques so that they are able to reduce the anxiety, and you counsel them on how to manage that anxiety. So clear communication is what these people need. Regular updates so that it keeps them off worry. They are the ones that will wake up at the middle of the night and call you just because they have remembered there's something that they did not ask. So we have the emotional roller coaster riders. Now, these are patients that experience intense emotions. So they are what you can call the bipolar, if you like, ups and downs, ranging from hope to despair. You must monitor them closely too, and help them to regulate their emotions, build their coping mechanisms and support them, acknowledge their emotional journey and validate their feelings. Now you validate their feelings, but help them to understand reality. We have the desperate seekers, and they are patients that can try anything. Patients that can come to you, they are on herbs, they are on orthodox, they are anything that will give them success in their head, they can be on that. So those are the patients that experience high levels of anxiety due to the urgency that they feel. What are the needs of these particular patients? Detailed information about available treatments, honest discussions about success rates, and then emotional support to cope with the pressure. So you must manage their emotions, expectations by providing realistic timelines. They are important because if they feel you are wasting time, they are jumping to the next option. So we need to be sensitive to these types of patients, okay? We have the disheartened and resigned patients who have faced multiple cycles and may feel disheartened. They are losing hope and they might consider giving up on treatment. As long as they show up at your door, you must do compassionate counseling for them, help them discuss about alternative paths to parenthood if they are giving up, because they are the ones that will tell you, I don't want to try anything again. So you give them other options and you must support them emotionally, okay? Then we have the guilt-ridden and the self-blaming patients. They are patients that blame themselves or their bodies for the challenges, even if everything is all right with them and they are not at fault. So they experience high levels of guilt, of shame, and low self-esteem. These are characteristics of depression. What do you do for these patients? You have to counsel and address their self-blame. support group where necessary to share their experiences, because talking about it helps them to cope, to heal, and to learn from other people's experiences. You help teach them self-compassion exercises and build their self-esteem to be able to address the guilt feelings. We have the decision makers, that's the next group of patients, and there are patients who have reached a point where they consider decisions such as adoption, surrogacy. So they come to you, they know what they want already, and so they just express that, and they are accepting this to explore that path of parenthood. What do? Of course, you support them. You also counsel them, and then you give guidance. You respect their decision, of course, while at it. We have the support seekers, very highly emotional patients that seek support at all times. They are open to therapy, to any coping strategy that will help them. And excuse me, involving their family members is important because they will need such support subsequently. So you give them access to support networks, counseling service, very key, acknowledge their efforts in seeking help, and encourage them to continue with that support. Now, the last set of patients are the difficult patients. If you look at my slides, you see that these people, let me use our cliche to say they're no send. It's the young people, old people, difficult. These are the categorizations. So we have patients that come with personality disorders. You must be a very sensitive person or a mental health specialist to be able to identify difficult patients and understand them to serve them better. What are the challenges with these patients? Communication is an issue. Okay, so they are not calm enough to actually communicate clearly with you. Consenting, sometimes they don't have the capacity or they are refusing to consent. They can be very unpredictable, and sometimes they threaten staff safety. What are we to do with these patients in this kind of situation? Of course, you stay calm. You involve psychiatry where there is need. I know we've had to send 1 or 2 patients to the psychiatrist because sometimes they are not in the right frame of mind to even calm down and get counseling. But you never try to confront any patient. We have number 2 on the difficult patient list, the prejudiced patients. These are patients that might not agree with treatment. They may compromise care and they think they know better. I'm sure that we have encountered such patients. What do you do with those patients? You educate them. You give them time to think about their decisions, about what they've heard. You offer alternative care, because I know in IVF, there is always a way out. That's what we say. So there are options. Then, of course, you remain unbiased with these patients. You never react to prejudice from them, and you never take whatever they say personally. So if you are professional, you'll be able to make success with this category of patients. We also have manipulative patients who play on the guilt of others. They threaten rage and legal actions. They say the right things just to get away with what they want, and they have a full or good knowledge of the system. They are the kind of patients that you're trying to attend to, but before you know it, from HR, you're getting called, or from management, you're getting calls because of the way you attended to them. So these are the patients, they have a very good knowledge of the system, and they they make good use of it. What do you do to these patients? You must alert the team, your staff members, your team, so that they are aware and careful and vigilant about these patients. You also involve other healthcare professionals where necessary. And of course, there are times that you may need to negotiate certain aspects of their care with them to be able to satisfy them. So what should you not do? Never confront. You must have firm boundaries. Clear communication, very key. You must be vigilant, like I said earlier, and then you ensure that care is provided for them maximum. Patients who speak a different language can also be a difficult situation. What do? We must be culturally sensitive in our treatments, because there are different cultures. Nigeria is a cultural and religious nation. So we must be sensitive to those things that guide the way people live their lives. We must show professionalism in all that we do. If they don't speak the same language, get a qualified interpreter, preferably a staff, because they'll be able to use the right terminologies, never a relative. You ask patients to summarize to ensure good feedback and that they understand. And then you use non-verbal communication where it is necessary to be able to communicate with them. So you refrain from being biased with these patients. You don't use children to translate. You don't focus on the interpreter, you focus on them. That's your gaze is on them while you discuss, so that you are monitoring their gesticulations and their cues. Then you don't use too many closed questions where they answer yes or no. You allow them to express themselves through the interpreter so that you understand how to serve them as well. So, in conclusion, the medical intervention certainly addresses biological aspects of fertility, but without the necessary psychological or emotional support, the treatment is compromised. What then are we supposed to do? Fertility counseling is everybody's business. So as a member of the multi-dimensional fertility team, we owe each of our patients we owe each of them we owe it to them, I'm so sorry, to empathetically go on this journey with them, because the journey of IVF, treatment, and the results is a very burden on our patients. Thank you very much. These are my resources.
Thank you very much, Mrs. Bamyil, for keeping to time. Such an insightful discussion from your end. Thank you so much. If we have questions and answers, please. I'm going through the question and answer. We don't have any yet. But Mrs. Bamyil, interesting discussion. I just want to ask, with this very interesting, or like say non-negotiable for me, for ART, so how would you advise, or how can fertility clinics integrate counseling as a core part of ART treatment to ensure that our patients receive holistic care? And also, we have a number of patients that will come in and outrightly reject, counseling, even, when we prescribe it. So how would you advise fertility clinics to make sure that it's a core part of ART treatment?
Okay, thank you very much for this interesting question. It has been beating on my mind too, how to do this. I want to give kudos to the ESCO of AFRH, because I know that their clinics have some form of counseling going on. Now, there are two forms of counseling that can be done. And what I'll advise clinics to do is that they can train their nurses on counseling in ART. If you went through my site from the beginning, I wrote the criteria or who should counsel. So a nurse can counsel. So clinics should take advantage of the nurses that are in their clinics and train them on the ART counseling. That's one. The second thing that can be done is, I know AFRH continuous education, this webinar series has different topics that will be discussed. This is one of them, so that we are able to be aware as of the importance of this counseling and then adopt it in our clinics. I hope I've done justice to your question, the first one.
Yes, definitely, yes.
So for the second question, I said counseling is voluntary, right? So patients can decide if they want to get counseling or not. But it should be part of the process of care that we are giving our patients. So if you have a roadmap, for instance, and on your roadmap from front desk to counselor, to nurses, to doctors, and it's outlined there. I don't think that a lot of patients will refuse it because it's part of their care. However, there are few that may reject it. You let them be. Now, there are aspects of fertility treatment that the counselor can be invited to consult with the patient, and then that counseling will be chipped in somehow. Sometimes it's individual, sometimes between doctor or nurse or embryologist and the patient, but there are certain aspects of the treatments that you involve the whole team. For instance, treatments like PGT, treatments for third party, it is very critical that counseling should be done so that all the aspects of it will be x-rayed and discussed and reality check is done before the patient continues with their treatment. Thank you, ma'am.
Yeah, thank you so much, Mrs. Ali, for that wonderful explanation. So thank you, Dr. Uzo Richard. So yes, this presentation will be shared on our YouTube channel, and the link will be shared with all our members, please. You can stop sharing now, Mrs. Sally. I don't know if we have any questions from the panelists.
Just some comments. Firstly, we must give kudos to the speaker. She has done thorough justice to the topic. Thank God, counseling has assumed greater significance, as it were, than say 15, 20 years ago in ART generally. Yes, you did a thorough job of that topic. Thank you so much. We all know that counseling is a team effort, and is gaining more role. There are some sore areas where ART becomes rather humbling when you experience them. For instance, having to deliver a negative result after an ART procedure. I mean, I always say to myself, why do I have to face this type of situation, for God's sake? I mean, it's a very terrible situation. And some people will delegate it to their nurses and things like that, but you won't have done justice to it because, like the speaker has said, when you are delivering such a sentence, you want to study the patient's countenance and be able to tap on it to be able to respond as a way of initiating a counseling strategy. I call them accidents because there are others. For instance, you are treating a couple and their donor absconded after 6 days of stimulation. You don't have frozen egg. Even if you have, they will not want it because they've already acquainted themselves with this donor. Or the patient you are stimulating has severe OHSS. Even though you have done some initial counseling, it rather complicates the already bad situation. So there are such periods in our effort to treat patients that we are confronted with very difficult situations. In these instances, counseling becomes even more important. And I mean specialized counseling, because it's not just a matter of the normal counseling and say, it needs a lot of professionalism input into it. And my hope is that as we progress in our discipline, we will gain more experience, we'll have more trained personnel to deal with these issues. Thank you very much, Dr. Saleh.
Thank you, sir.
Thank you very much. Thank you very much, Dr. Gukea. Thank you. You mentioned the issue of the stress in breaking bad news, because luckily that is one of the topics that we will be covering during our counseling series as well. In fact, we will be having that in another 2 weeks, and it will be delivered by our very own Dr. Elijah Udiwe, who will be talking through when treatment fails, how to break bad news. So please, let's look out for that webinar in another 2 weeks. so that we can, get to the nitty-gritty of what no one wants to do. Breaking bad news. Mrs. Abiola Deusi, go ahead, please.
Yes, good afternoon. Mrs. Sally, thank you very much for that lucid presentation. You covered every single bit of it within that designated time. Thank you very much. It was quite insightful. But what I wanted well, should I say emphasize or maybe even ask a question, because we know that it's a reality that we face every day when we're trying to counsel those patients, is that as a clinic, we have to offer this service. It's almost natural to offer this service. So we try to engage or train our nurses or embryologists or whoever is in charge of coordination, front desk people, because like you said, counseling is even from the gate, the security guys, the way and manner they respond to this patient is part of counseling, whether we want to believe it or not. But we soon realize that it is not every member of staff that is cut out to do this. So my question is, is there a system in place to streamline who takes care of this intensive counseling, as opposed to assuming the next person is going to do a good job of it, because there are some people that just can't do it. It doesn't matter how you train them, how you counsel them themselves to counsel patients, they just won't do it. They really do bad at it. So is this something that we identify, and maybe there's a way it can be corrected, so that we can better help our patients?
Okay, thank you very much, Mrs. A. It all boils down to personality one, and then staff selection. I know that in my facility, we select who works in the IVF clinic. And that's, you look at the person's presentation, you look at how they address issues, when they're angry, when they're not. So you identify from the person's personality and the kind of work that they do, and then you give them such responsibilities. Now, that alone is not enough. There must be training to do what they can do, right? So I've said fertility counseling training, not just book, but exposure. Now, in my facility, there was something we were doing at our clinical meetings. Okay, you attend to patients, how do you do it? You call patients, how do you do it? So they tell us how they do it. When you call them for this situation, what do you say? So we correct. So there's an on-the-job or in-house training, so that you are able to invest in that person, what you want them, what to see. So personality, very key, and then willingness to train, and then staff selection. For me, those are the things. Thank you.
Yes, I quite agree with you, Mrs. Sally. And just to corroborate what you said, I don't know if we've all had the privilege of looking at the AFRH guidelines. For counseling, it says that clinics must provide the access to counseling services by appropriately trained professionals who possess the skills, experience, and competency to help couples and individuals undergoing ART to make an informed decision about their treatment. And it even says before, during, and after their procedures. So I think it will help us to just go through those guidelines. Just like you said, a lot of scenario, trainings and practices as well to help, our counselors as well for those specific, counseling. Yes, Dr. Akinola, please, you have the floor. Dr. Akinola is the chairman for the training committee. A few words from you, sir.
Yes, Honorable Moderator and our Secretary General, thank you for moderating this webinar. More to come, and I also want to give a thanks to our senior colleague, very, very senior colleague, Dr. Michael Ogunkoya, for acceding to be part of this webinar as well as a moderator. Thank you, Mrs. Saleh, for your lucid webinar, and it's quite comprehensive. And I want to highlight one decision that we have to inaugurate this webinar. And I want us to use it as a means, we have this target to write a textbook. Please, this is the needles of the textbook. So Mrs. Saleh and all the webinar, including myself, we are enjoying to please, once you do your presentations, listen to, get grips of the questions that were asked to help you to develop a manuscript that you can submit for the textbook. And also, this is also an opportunity for you to get, references, get grip about writing manuscripts. And if you have any queries, please let us know about your queries. We can assist in producing your manuscripts. And I also want to thank everybody that has, indicated that they are going to participate in this webinar series leading to a textbook for AFRH on infertility. There are 3 areas I want to point out, please. Mrs. Saleh, you may want to delve more into it. Counseling, I quite understand that, and I agree that not everybody might be skilled enough to counsel. And so we need to be very careful when we are doing it. There are 3 areas that I want you to highlight when you submit the manuscripts, please. We're out to counsel a patient that has been undergoing fertility treatments for some few years, and then she got pregnant, and then now have to do D&C because of blighted ovum or because of biochemical pregnancy. The other aspect that is also very important, these days we have a lot of age-factor infertility, not voluntary, but because they have to undergo a lot of career developments, they may come up late. So when you have a patient that comes with AMH of 0.001 or something like that, or somebody that can't carry a pregnancy, how do you convince them, maybe in your write-up, just give us a brief, how to convince them that, look, this is your AMH, although it's not something that is sacrosanct, but it is advisable when you are going to do your IVF treatment, you need to do donor backup. So those are realities that we face, commonly. So it's better for us to know how to do this counseling. The third area is how do you counsel a patient that, look, you have done IVF, we have used all avenues to make sure that you get pregnant while you are doing this. This is going to be your 15th IVF cycle or something, like that. How do you counsel such patients to shift, treatment modalities, possibly to adoption, or to accept that, look, these are the realities of things. My doctors have tried, I've spent a lot of money, and now for me to move forward and look forward to do something? Or how do you counsel the AFRH? Mrs. Rose was talking about AFRH guidelines, Lagos in the Lagos State guidelines that look, 54, 55 is the barrier. So how do you convince a woman that comes at 56 or somebody like that that is very, very adamant that, look, I don't care what your AFR is saying, but I have to do this. How do you counsel such patients to say, look, because of your age, because of certain factors that are peculiar to pregnancies, we need to, we may have to advise you to take to another options. Thank you so much.
Thank you, Dr. Akiola. Thank you for those submissions. I think it's clear that for us to really appreciate counseling, we have to put a little bit more of scenario presentations, especially with what we face for our day-to-day practice, Mrs. Sally. I think we'll be glad to see that in the final write-up. We have a quick question from Deborah, and she says, how can we standardize and unify the counseling process in IVF to ensure consistency across all members of the team? And then how can this counseling be unified to avoid mixed messages and ensure patients receive consistency and accurate guidance? Can you answer that question for us? Maybe in a few minutes, please.
Okay, well, I know that there are guidelines for what we do, and I belong to several counselors associations, and there are guidelines. I know British Counselling Society has, I know that APA, American Psychological Society has. Counseling is a relationship. You cannot it's not devoid of the truth. So it's telling the patient information which is true and guiding them to decide. So it's not it's not from you, it is you carrying them on the process of, or on the journey that they're about to go on. But there are certain, there are key things to look out for while counseling. I think I enumerated some of them, but what we can do is to produce a part of the guidelines and put on the AFRH guidelines for counseling and add it there so that it is standardized, like you have said. So it's devoid of self. It's more about the patient, about the information, about the process, and less about the counselor. So there's no interpersonal anything over the patient.
Okay, thank you very much.
Rose, you're unmuted.
Oh, so sorry about that. Deborah followed up with another question, and I think you just spoke briefly about that in terms of standardizing the counseling framework. So I think that is very, very much needed, especially with the updates to the AFRH guidelines as well, so that we can have a consistent approach to counseling. So thank you very much for elaborating on that, Mrs. Sally. And just again to thank the members of the ESCO. I see Mr. President and a lot of ESCO members on the platform. Our Vice President, Mrs. Biola Adeosi, thank you for joining us. Mr. President, Professor Pibai Priye, thank you for joining us. And just to remind us again, this is the counseling series, and our next series will be in 2 weeks. And we will be learning about how to break bad news. I'm sure a number of us would like to, know that as a follow-up to this presentation as well, because I know breaking bad news is never easy. So Dr. Elijah is going to, give us some tips and tricks, if there are, to learn how to break bad news. I'm not sure we have other questions again, and I see that you've answered one already. So thank you very much, Mrs. Saleh. It was such a pleasure having you share your insights on counseling in ART. So until we see again, it's thank you and good evening to everyone, and thank you for joining as well. See you in 2 weeks.